The patient is a 30-year-old male. He has been diagnosed with type 1 diabetes for 10 years. He presents to the ED with a blood glucose level of 550 milligrams per deciliter, and his urine is positive for ketones. He appears acutely confused. His breathing is rapid and deep. He is diaphoretic and has nausea and vomiting. I'm going to start by assessing the patient's thorax. The chest is moving equally during respirations. The respirations are rapid and very deep. The AP to transverse ratio is 1 to 2. I'm then going to assess the patient's symmetric expansion. I'm going to do this by placing my thumbs at the level of T9 and wrapping the palms of my hands around the rib cage parallel to the rib cage. I'm going to ask the patient to take a deep breath in, and this patient's symmetric expansion is normal, and my thumbs move apart 5 centimeters equally. Then I'm going to assess the patient for CVA tenderness, and I'm going to do this by placing my hand at the level of the costovertebral angle, and I'm going to make a fist with my dominant hand and just tap on my hand to see if there's any pain elicited. I'm going to perform this bilaterally, and this patient has no pain that's elicited upon percussion. Next, I'm going to auscultate the patient's posterior lung fields, and I'm going to start above the scapula, and I'm going to listen from left to right, making my way down from the apex of the lung to the base of the lung, and I'm going to end my auscultation at the mid-axillary line. Then this patient's lung fields, posterior lung fields, are clear and equal bilaterally. Next, I'm going to assess the patient's anterior lung fields, and I'm going to start above the clavicle, again moving from left to right, making my way down through those intercostal spaces, and I'm going to end my auscultation at the level, at the midclavicular line at the 6th rib. This patient's anterior lung fields are also clear and equal bilaterally. Then I'm going to assess the patient's cardiovascular system. I'm going to look at the patient's fingernail beds to see what color they are, and they are pink in color. The capillary refill is less than 3 seconds. There's no clubbing that's noted on the patient's fingernails. I'm going to assess the skin turgor, and the patient's skin turgor is abnormal, and it takes longer for the patient's skin to return back to normal. Then I'm going to locate the PMI, which is at the left midclavicular line at the 5th intercostal space. This patient's pulse is rapid and weak. It's 132 beats per minute. Then I'm going to auscultate the patient's heart valves. At all 4 valves, I'm going to start with the aortic valve, then I'm going to move to the pulmonic, then the tricuspid, and then the mitral valve. S1 and S2 are noted for this patient, and there are no extra heart sounds, murmurs, or clicks that are noted on auscultation. Then I'm going to assess the patient's peripheral pulses. I'm going to start at the radial pulses, and I'm going to palpate this bilaterally at the same time. This patient's pulses are 1+, and they are rapid and have a regular rhythm. Then I'm going to assess the patient's brachial pulses, and I'm going to do this bilaterally. They are also 1+, rapid, and with a regular rhythm. Then I'm going to assess the patient's abdomen. The patient's abdomen is equal and round. There are no lesions, lumps, or scars that are noted on inspection. I'm going to auscultate the patient's abdomen starting at the right lower quadrant, working in a clockwise fashion, and ending in the left lower quadrant. The patient's bowel sounds are hyperactive and auscultate in all 4 quadrants. Percussion elicits tympany in the right lower quadrant, left upper quadrant, and left lower quadrant, and dullness is elicited in the right upper quadrant over the liver. Light palpation, there's no masses or lumps that are noted, and deep palpation elicits pain and tenderness.